but I also hope that it's a talk that's got some practical implications. And I'm very conscious of the fact that it's 5 p.m. your time, which I regard as being a particularly hardcore time to tune into an educational meeting. So I hope this won't be too boring. And let's go. So I'd like to start with a couple of principles that I think affect the practice of medicine the world over. And the first is the sort of principle that doing is better than not doing. And also that I guess knowing is better than not knowing. And, maybe they're better described as biases that affect decision-making for doctors and patients. But, I think it's pretty entrenched, this idea in human nature that if there's a problem, it's surely better to know about it. And having identified a problem, it's surely better to treat it than not to treat it. Okay. Now, of course, this is a false dichotomy, right? So I don't actually really believe that that in absolute terms, these positions are tenable either way. But like no sane person would believe that these statements are either entirely true or entirely false. So they can only be partially true and by extension, partially false, but it's clearly not 100% true that it's always better to know, right? So not long ago, I saw a patient who went to his GP with a non-specific and mild urinary complaint, had a mildly abnormal PSA, subsequently had a prostate biopsy that was complicated by the development of a prostatic abscess that led to fulminant gram-negative sepsis, multi-organ failure and death. And it turned out his prostate was normal. And even if it hadn't been, I would sort of argue in this particular instance, the price of knowing on any reasonable assessment was pretty high. And so perhaps a better way of thinking about it is this, right? There's a spectrum that at one end has know nothing and do nothing, and at the other end has know everything and do everything. And so at the beginning of my career, I started out closer to this end, and now I'm down at this end. And I guess this talk is about asking you to join me and leave the dark side. Come and join me on the side of the light. So I'm going to tell you, I guess, a little bit about how I got to believing what I believe and why I believe it. And it's sort of a complicated journey in a way, but I guess I work full-time in intensive care as a clinician, and I've seen some stuff and I've done some clinical research more than average, and I've read some stuff and I've studied some stuff, and I'm going to tell you a little bit about how my journey has articulated my thinking. I mean, I want to emphasize again, this is not about absolutes, and it's not about whether the two statements that I mentioned at the beginning are right or wrong. It's more just about why I actually believe that they're more wrong than right, and the consequences of misjudging how wrong or right they are, well, they can be quite significant. So for me, the story starts in the 1990s. And I had a hard time getting into medical school. So in New Zealand, most people apply to medical school straight from high school. And I wasn't brainy enough. So I went to university and I did a physiology degree. And at the end of my physiology degree, I applied to a bunch of medical schools in New Zealand and in Australia, but I didn't get in. And so I did an honours degree in renal physiology where I performed surgery on rats to elucidate the role of the renal nerve and alpha-2 receptors in the response to volume expansion. And after that, I did finally manage to get into medical school. But I do think actually my background in physiology affected the way I thought about things to a substantial degree. And I really think as I progressed through my training, I fundamentally, I believed basically that intensive care was sort of this ultimate in applied physiology. Here's the paper from my honours degree. There are certainly more of you listening to this talk than have ever actually read this paper, but I thought I'd put it up anyway, just for fun. During my training, I think, that my belief system was pretty heavily influenced by Manny River's early goal-directed therapy study. And it's not that I ever actually did these things exactly, but in general terms, I really did think like this. I thought that intensive care was about defending normal physiology by and large. For my first randomized controlled trial, I investigated this thing called remote ischemic preconditioning. I'm not sure if you've heard about this. We studied it in high-risk cardiac surgery. And essentially the idea is this, like you inflate a blood pressure cuff on the patient's arm for long enough to render the arm ischemic. And then you deflate the blood pressure cuff, and the ischemic tissues, they make stuff. And then when you let the cuff down, the stuff is released into the bloodstream and it circulates around the body, makes its way to the heart, which then preconditions the heart for the ischemic insult that occurs as part of cardiopulmonary bypass. Now, this is a randomized controlled trial, which to my current way of thinking, assessed a treatment strategy that was as likely to improve meaningful patient important outcomes as casting magical spells. And the reason why that's the case, I think, is that after cardiac surgery, most patients do well. They require a period of intensive care, but provided you don't do anything too outrageous, they'll be pretty fine, right? So cardiac protection on cardiopulmonary bypass might not be perfect, but it's pretty damn good. And it's probably good enough that unless some sort of mishap occurs, it won't be a determinant of outcome. And mostly when mishaps occur, it's still hard to believe that remote ischemic preconditioning would help, right? I once saw a patient who had a dead right heart because during the aortic valve replacement, the cardiac surgeon inadvertently sutured an aberrant right coronary artery closed. In that situation, myocardial ischemia is clearly an important determinant of outcome, but no amount of remote ischemic reconditioning will revive an infarcted right ventricle. And so even when mishaps do occur, it seems pretty unlikely that they are going to be remedied a lot of the time by inflating a blood pressure cuff on a patient's arm during their operation. Now, the purpose of this minor digression into my first ever randomized controlled trial is that as part of that randomized controlled trial, I incorporated some standard hemodynamic goals: cardiac index of at least 2, a mixed venous saturation of at least 60%, and a mean arterial pressure of 65 millimeters of mercury or more. Even now, these don't really seem like they're very lofty goals. I'm not going to go into the details, but in short, in this trial, we sought to standardize the management of patients to achieve these goals, irrespective of which treatment group they were assigned to. And we had an algorithm that optimized fluid status based on fluid responsiveness, and we reduced afterload where we could, and we optimized cardiac output with a hierarchy of inotropes, and we maintain blood pressure with pressors. And in the end, compared to what we'd been doing before we started the trial, we ended up doing more of everything. We gave more fluids, more pressors, we had more complicated treatment. And in the end, we ended up requiring more intensive care. We had more of doctors being clever and complicated, but to no avail. So here's an alternative way of thinking about post-cardiac surgery care. If you see the patient in the intensive care unit, you can ask this question: if I don't change something, will the patient die? If yes, change something. If no, don't change anything. Because the thing about post-cardiac surgery care is that the cardiac surgery is in the past, and the natural history of the post-cardiac surgery patient is to get better with time. If they're getting better, then they're going to continue to get better, and you should really avoid being meddlesome. And so a more nuanced way of thinking about things is when you first see a cardiac surgery patient is just to put them in one of 4 categories. The first category is stable and simple, and this includes things like an aortic valve replacement or a CABG with a normal ventricle on a low level of support. And you know, these are patients who likely, some of the time at least, even if they were extubated immediately post-operatively on the roadside outside the hospital, they would actually live. And so the plan for these patients should just be to desedate and extubate. The second category is stable and complicated. And this includes things like a mitral valve plus a CABG or thoracic aortic valve, thoracic aortic surgery, you know, that sort of thing. And here the important thing to understand is that sometimes the patient who looks, sorry, excuse my dog. Sometimes the patient who looks stable and uncomplicated actually is going to look worse in a few hours. And the best thing to do here is to give them a bit of time to crap out if that is indeed their destiny. So the plan for these patients actually is just to wait and reassess the situation in 4 to 6 hours. The third category is unstable. So this group, either the pressures might be going up or blood might be pouring out the chest drains or something like that. And these are patients who you might reasonably recognize as potentially going to die if you don't change something. Now, the fourth category is the ones who turn up to the intensive care unit receiving neat adrenaline boluses or vasopressors in such high doses that they are contributing to fluid overload. And basically here, your job is to call the family and provide clarification that when the cardiac surgeon rang them and told them that the operation was technically successful, that there was some additional relevant information to the patient's outcome that they should know. I think it's kind of important that everyone has the same shared mental model of the situation. And so I kind of like when the patient arrives in the intensive care unit and people are giving a handover to sort of distill it down to one of these 4 things. You know, I just try and make it really simple like this. And there's a risk that it means people will think that I'm slow-witted. But if I think that the patient is stable and simple and the anaesthetist thinks that they're unstable, then that's probably an important difference in understanding to clarify. So, you know, I think the point that I have come to here is that it turns out the paradigm that it's all physiology is completely wrong. Because the physiology is not supposed to be normal. The physiology is supposed to be abnormal because the patient is critically ill. And actually, we have seen this time and time again that improvements in a patient's physiological state can ultimately lead to a worse patient outcome. And the really big problem for us as clinicians is that we are subject to availability bias. The physiological gain of interventions is often immediately available, whereas the ultimate benefit or harm in terms of a patient outcome is remote, and it generally can't be discerned by looking at what happens to an individual patient. In my career, there have really been 2 examples of clinical trials that have framed my thinking in this regard. The first is the Decorah Trial, and the second is the Feast Trial. You know, we know that having a high intracranial pressure is abnormal, but there are actually good randomized controlled trial data from Randy Chestnut's study conducted in Bolivia and Ecuador that showed that care focused on maintaining an ICP at 20 or less is not superior to care based on imaging and clinical examination. And so maybe there's an argument here that knowing actually is not better than not knowing. We know that responding to intracranial hypertension by chopping off the patient's head makes the ICP go down, but both the Decorah trial and the rescue ICP trial showed that decompressive craniectomy does not improve outcomes and may well make them worse. So here it's entirely possible that doing might be worse than not doing. You know, the dogmatic interpretation is that the ICP in rescue ICP stands for intensive care problem. But the problem though, and the reason why decompressive craniectomy won't go away is that sometimes the physiological disturbance is so severe, the ICP becomes so high that it becomes highly probable that if you don't do something, that death will occur. And so I think that's a challenge in this space, right? Which is that we know that in randomized controlled trials, this therapy makes outcomes worse, but we also know that it can prevent death. And so that is a challenge. The second trial, which will be well known to you all, I'm sure, is the FEAST trial. This is a trial that looked at fluid boluses or no fluid boluses for African children with severe infection. And fluid boluses turned out to significantly increase mortality. There's an interesting video about this trial that you can see on YouTube. And the part that I think actually is most interesting is the footage of the local investigators shaking their heads in disbelief when they're told the results, and listening to them say how they can't believe that they could be true because they'd treated the children who'd been allocated to fluid bolus therapy and had seen how much better the fluid made them look. So, you know, unfortunately, in the developed world, we haven't got past the fact that the fluid makes the people look better. It's possible that giving fluid boluses improve physiology and kill patients. It's certainly true that that's what happens to children in Africa. We know that we can normalize tidal volume and kill the patient. We can normalize the blood sugar and kill the patient. We can treat the fever in a patient with an infection in the intensive care unit and not help them. We can maintain a normal mean arterial pressure and not help the patient. We can use some therapeutic hypothermia to increase adverse events. And, you know, we can treat oliguria, which is, you know, a normal state in the intensive care unit with IV fluid. And that will just slightly precipitate fluid overload, particularly if the patient has an established renal injury and can't manage the salt and water load that you are giving them. You know, in randomized controlled trials in the field of intensive care medicine, there's another major problem that is really relevant when thinking about this issue of doing too much stuff. And that's that adverse events are systematically underestimated in randomized controlled trials in intensive care medicine by design. Everybody knows that intensive care patients experience a number of common aberrations and laboratory values and signs and symptoms that are due to the severity of their underlying disease and the impact of standard therapies. And because that really makes adverse event reporting of every adverse event in an intensive care study impossible, the standards for reporting of adverse events in critical care trials are generally different from in other studies. Generally, the reporting of adverse events in critical illness is confined to events which are considered to be potentially causally related to the study intervention or of concern to the investigator. Such reporting by design is subject to bias, And it's highly likely to mean that adverse events are both underreported and underestimated. And so a key principle that comes from this is that it's very likely that if you do something, you will be underestimating the likelihood of that something causing harm. So unless you're in a situation where all reasonable doctors would come to the same treatment conclusion as you, the narrative that you create in your mind to justify the treatment that you are providing is doctor-centered, not patient-centered. Because if only you can think of it, it's not about the patient, it's about you. So finally, here is my modus operandi. I think that being critically ill is like being thrown from an airplane, and that intensive care units are like parachutes. Now, without a parachute, being thrown from a plane is almost uniformly bad. And there are some situations where a parachute won't help you. If you are too close to the ground, or if the airplane is the Challenger space shuttle, that sort of thing. But actually, modern ICUs doing simple stuff make pretty good parachutes in the main. And if you have a parachute, you will be okay. It's important to understand that having developed a working parachute, you can expect that your parachute will work most of the time. And indeed, it's implausible that most modifications to your parachute will dramatically alter its effectiveness. It is really important to remember, though, that every time you fiddle with your perfectly good parachute, you risk a malfunction. Now, I'm not saying that you can't make refinements to your parachute. You can't add additional stuff. You know, I mean, there's nothing wrong with adding some additional stuff. You just have to remember to pull the ripcord. And you have to always keep in your mind how far away the ground is. So it's important not to be subject to fixation error, because in this metaphor, just to be clear, the ground means that the patient is dead. So I think that the most fundamental part of the clinical assessment in the intensive care unit, and the part that actually matters, is going and seeing the patient and thinking to yourself, if I don't change something, will the patient die? If the answer to that question is yes, then you should change something. The answer to that question is no, you mainly shouldn't change anything. Remember that an internal narrative that leads to special treatments that only you were clever enough to think of leads to doctor-centered care, not patient-centered care. And the aim of intensive care is not to improve physiology. It's not to seek physiological gain. It's to do whatever is required to prevent the patient from dying whilst minimizing the risk of iatrogenesis. Now, it is important to frequently swing past the patient and get a sense of whether or not you might have misclassified them. But in the main, you should try and have as much coffee as possible. You should talk to your colleagues from different disciplines in the coffee queue so that you get to know them and they get to know you. You can't expect them to understand the importance of doing nothing. So you need to try and figure out a way to make them trust you. And if possible, I think it's always better to try and make a connection. So it's not just about colleagues, it's also about walking around and sitting down at the bedside with visitors and telling them about who you are and asking them about who they are and asking them about their loved one, and maybe arranging a family meeting for later, but trying to connect first. You know, maybe ask them if they would like a coffee. As a general rule, I think maybe we spend too much time on direction and not enough time on connection. And I think that's a really important thing to say and to think about, because if you manage to actually form some sort of connection, then the direction part will be much more straightforward. I think that building trust is something that is underrated and that we don't spend enough time on. Now, I don't want you to believe that I don't believe in anything at all, because I definitely do. I think that it's very believable that we can, through randomized controlled trials that are carefully considering ways in which we can subtly alter our parachute, that we can have massive population impacts that are for the greater good of patients who are critically ill. Here's some recent clinical trials that I've been involved in. This is the PLUS trial, which showed that saline's really not that bad. But at the same time, if you put all the evidence from randomized controlled trials together, it does look like balanced crystalloids are usually just a little bit better. Therapeutic hypothermia does not improve outcomes for out-of-hospital cardiac arrest patients, and it's associated with adverse events. Critically ill patients aren't very hungry. Accelerated initiation of renal replacement therapy is on balance harmful. And that's my Twitter handle, and that's my email address. And thanks for taking the time to dial in and listen to me talking at 5 o'clock on an afternoon. The end.
Well, thank you, Paul.
I'm happy to take any questions.
That was exactly what I expected. That was terrific. We will, I'd like to open it to questions from the crowd. You can either raise your hand on the Zoom emoji or type it in the chat, or if your camera's up, Wael Hedera has his hand up. Why don't we take one from Paul? Dr. Hedera is our chair chief of our academic and hospital critical care program here in London, Ontario. Take it away, Wael.
So thank you very much, Paul. This is very near and dear to my way of thinking. The only thing I'm going to say actually is to ask Paul Cameron to comment, because I know it's also very near and dear to his way of thinking.
I can maybe jump in. Thank you very much to Dr. Young. I guess I sort of two questions. One is this is the sort of fourth or fifth very sort of high level person in critical care who's had a similar vein to what you've sort of laid out. So I'm curious why you think the pervasive attitude is contrary to what you said. You know, Dr. Tobin, Dr. Singer, Dr. Vincent, all kind of espouse similar views that doing less is more, but yet it seems like that's the bucking the trend. So if all the thought leaders are thinking like this, what accounts for the culture? And then I wonder if you could comment on the role of point of care ultrasound and how that fits in here, because I wonder if there's some element of, if you see something, say something. If you do an echo on someone who's well and their EF or their stroke volume is 10, are you similarly advocating for sitting on your hands? Because I feel like that would hopefully be a spicy comment or discussion within this group.
Yeah, I mean, so I think the reason that people who are involved in critical care research think like this, I think, is that if you're involved in critical care research, it's impossible not to come to this position eventually, basically. I mean, I think that it's really what the data show. But I do think that the availability bias that I talked about is a pervasive thing that makes people do stuff. And you see it with junior doctors and junior specialists, right? So the more junior people, when faced with a problem, they will always do stuff, you know, and very often the most senior people will do the least. And that's definitely the case in my department. So, you know, in my department, the people who are closest to retirement are the most likely to respond to a situation by saying, yeah, okay, I'm not going to do anything. Yeah. And so I don't know, I think it is very difficult to get to the position of seeing a thing and not doing anything. And actually, I do think that ultrasound makes it even more difficult to do that, right? Because it's another thing where you can see stuff with your eyes that make it hard to not do a thing. So, you know, like the classic thing I think is, you know, put the ultrasound on the probe and see that the left ventricle is absolutely going gangbusters and it's contracting so that the ejection fraction looks like 100%, and saying, oh, it's hypovolemia, and then giving fluid, and then the blood pressure will go up, and then you'll say, aha, there you go, I was right. When in fact, you know, actually the problem was the patient had profoundly vasodilated and low afterload, and it looks identical and you can't distinguish the two. And actually the reason it looks like that is because that's the patient's physiological state, and doing nothing would have been perfectly fine. But having seen a picture that looks so dramatic, it's really hard to resist, particularly if you're a relatively junior person who's picked up a new skill and found a thing. So, you know, I do think that point of care ultrasound does pose some challenges in that regard, but it is sort of also something that will occasionally show you a diagnosis that means that the patient is actually going to die if you don't do something, right? So I don't think it's a case for saying it's not a useful thing to do. It's just actually, I do think that the way to use it is much the same as you might use any other piece of the clinical information, which is to try and make you determine whether the patient is actually in a situation where if you don't change something, they're going to be in trouble.
Thank you very much. Yeah, I think I'll pass off to John.
Thanks very much for a great talk, Dr. Young. I think just getting to one of your points, you know, this is something that Paul and some of my other junior faculty colleagues talk about a lot, is that sort of enlightened nihilism, but towards like, I guess like the sociological theater aspect of working in a team in a critical care environment. If Weil Hedera and Rob Arnfield choose to not act, it's often seen as coming from a place of wisdom. And when you first start behind the 8 ball to some degree, inaction sometimes seems like it's coming from a place of ignorance. I'm not sure if you have any thoughts or approaches to the masterful inactivity to the early career intensivist as it pertains to the way that you've thought about a lot of this.
So, do you know, that is such a brilliant question, because I think actually a lot of the time, right, when the nurses ask you questions, they are not actually really asking questions, they're seeking for you to do a thing, right? So the questions are usually in code, right, which is code for, can you please prescribe X, or can you please do Y? And when you actually want to respond to that by saying, oh no, I don't think we should do anything, that means that they think that you're stupid because you didn't actually respond to the question by giving them the answer that they were actually wanting. So I actually find that I think that in that situation, the best thing to do is to immediately decode the question. So if they come up to you and they say, oh, I'm very worried that the blood pressure is going down, which is, you know, they're saying it's a code for, can you prescribe vasopressin or whatever. Then you say, oh, would you like me to prescribe vasopressin? And then they say yes. And then you say, oh, I actually, you know, I get it. It's what a clever thing to think of. But no, I don't really think we should do that now, because I think we'll just wait and see what's going to, you know, like if you actually demonstrate that not only do you understand the question, but you know the answer that they are seeking, that empowers you to be able to give a different answer to the one they wanted. Maybe, I don't know.
Thinking out loud to some degree, I guess. That's helpful.
Yeah. I mean, I think, you know, quite a lot of the time, I find, on the situation you go on the ward round, right, where the nurse will ask a question, which is a code for wanting a thing, and the junior doctor will respond to the question, giving an answer that doesn't deal with the coded thing that the person actually wants. And then I'll say, no, what they actually are asking is, can you prescribe hydrocortisone, right? Even though that's not what they said. And then the nurse will say, yes, that's what I was asking. And then I'll say, no, we don't need that. Yeah.
Thank you very much.
Wow.
Yeah. So Paul, I'm intensely interested in knowing if you've read The Doctor-Nurse Game by Stein.
No, I haven't.
You should definitely read that. It's a paper from 1967.
Right.
Archives of General Psychiatry. It describes a game that nurses play. You've basically summarized it in the last sort of 2 minutes, which is nurses do not make recommendations, they ask questions.
Yeah.
But if you don't understand that the question is a recommendation, you will be woken up at 1 o'clock in the morning for an order for Tylenol. Right. So, and the way to prove your credibility is exactly as you've described. It's really fascinating phenomenon that we see play out. And this kind of thing, and this is my actual question is, do you teach your residents these things or your fellows? I mean, do you spend time talking about these meta skills of understanding and communication? Because this is not how we teach communication skills. This is not how we teach, running rounds.
Yeah, I mean, in a didactic sense, no. But I mean, I think, it's a learning by doing environment, right? So, I mean, I think in a sense, yes, I think I do teach people those skills on ward rounds, basically, but not in a direct sense. I don't.
That's a shame. Because that's,
I mean, I do think, like it is true that the core of the talk, the doing stuff thing, right? It's very hard to not do stuff. One of the things that we've got a new person who started just recently as a fellow who's been with us for 2 months and has done more bronchoscopies in the last 2 months than I've done in the last 5 years. And it's very hard without completely undermining that person to get them to stop doing that. Yeah.
Alex?
Thank you so much. I really, really enjoyed your slides and the simplicity of describing the parachute analogy. That was brilliant. I haven't thought of it that way before, but it really resonated. I was just wondering what potentially a danger of such an approach might be to junior trainees, particularly, I definitely agree with everything that has been said by our seasoned clinicians, by yourself, and by everybody who's presented in this forum, that potentially, that doing more is actually potentially harmful. But how do you teach that to more junior individuals who might take this in a wrong way and potentially choose to do nothing for everybody? Like, where do we draw the line, and how do we pass the message that there are certain situations that still require us to act actively? Or is it just simply that, it's with time that they will acquire their own skills? But what I'm just worried about is that the more junior individuals will potentially become nihilists too early.
Yeah, that's another really great and insightful question. I mean, I think the thing is that actually what it takes to become a specialist or to become a senior doctor in critical care is to learn the ability to realize when the patient is in trouble, right? And you can't just know that. So the only way you can learn that is through practice. And so I think basically the answer for people who are junior, and the message that you have to give to people who are junior is to ask a lot of questions and to listen to what the nurses tell them actually. And what I mean by that is really, if the nurses tell them something or the nurses say that they are worried, then they should always be worried. And if they can't understand why the nurse is worried, then they should ask someone more senior, right? And so I think really there's no substitute for experience. And it is a really important message for people who are relatively junior to just not assume that every patient always is going to be fine and no one's ever dying, because, you know, 10% of the people we're looking after in the intensive care unit or whatever, they're actually not going to survive their hospitalization. So we do have a lot of people who are dying, and we do have to sometimes do stuff. And I think actually getting that message across is important. But by the same token, I think, you know, like there are often situations where even the junior people realize that the patient is actually not in a situation where they might die, but where they might still have an inclination to doing more stuff because they just haven't actually thought, well, what about the option of just doing less? And I guess an example I'd give you of that would be the other day, one of our registrars, you know, had seen a patient that'd come to the intensive care unit after having had a laparotomy, and they were just on a low dose of vasopressors going peripherally, right? And they were planning on putting in a central line and starting some, you know, noradrenaline through the central line as opposed to the stuff that was running peripherally. And all the numbers, if you looked at the chart, were getting better. You know, like everything was getting better. It was clear that if you did no other thing other than what you were doing, then in a few hours, the problem would be gone, right? And so I was like, well, you know, what's the pros and cons of this situation here? Like, why do you want to do the thing? And they're like, well, you know, because the patient's on vasopressors and so they need a central line. It's like, well, you know, sure, but really, do they? And then they're like, well, actually, they can see that the patient's getting better. And actually, when you put it to them like that, their objective assessment of putting all the information together is not that the patient really would be better off with a central line. It's just that that's what they expect to happen. And so I think, you know, it goes both ways, really.
Thank
you. John?
Thanks, Dr. Young, for an intriguing talk. And as someone who's kind of going into his 4th year of independent practice, many of the things that you said have resonated with me. And kind of as I look back in my, you know, in my earlier years, I do recall kind of being a little bit more active and doing more things for patients. And you know, now I look back and I reflect, you know, how much of the, you know, the plans that I put into place and the services that I've tried to push to do interventions are really true meaningful milestones for patients, or are they milestones that I'm trying to hit in my own head to create a narrative that I'm actually caring for a patient? And I'm actually wondering if this is part of the natural life cycle for all intensivists, where we start off by doing more. And as we gain that experience, we have the confidence to do less as we kind of move forward.
Yeah, I mean, I think it certainly, that's true to an extent, right? But I mean, I think you just have to look at the way vitamin C therapy has been embraced, right, in a lot of different places, to understand that there's still a lot of people out there who are grappling for magical stuff to be able to fundamentally change the way that we practice medicine. And so I think there's still certainly a lot of appetite for doing stuff at various levels, for sure.
Alex, you had your hand up again. I assume that you've gone off camera because you're good. But if I'm wrong, please raise that again. Paul, I wondered, you touched on the notion of the nursing kind of code, and the Rosetta Stone to decode that is actually one of the ways to avoid kind of the incremental doing stuff culture. But you did touch on in your talk that we don't work alone, and very often we are at the mercy of, or at least sharing patients. Certainly, I know at the Wakefield unit, I think you do cardiac surgery, you know, and certainly surgical patients. There's a lot of others who have skin in the game, where doing stuff is very important as part of that, their culture. And diffusing other colleagues' interest in doing stuff is, I found, traditionally much more challenging over time. I don't know if you could share some of your experiences there, knowing that you may be able to de-escalate sort of the nursing culture a little bit towards doing things, but how do you cope with consultants and other staff?
Yeah, so that's a really great question. And I think that the answer to that question is that you sometimes can't. So you have to choose the things that matter, right? So if you decide that you're going to have a fiery battle about whether someone receives 50 mils an hour of maintenance fluid or not, then you will make your life very unpleasant, and B, you will make everyone hate you. And so I think that you need to let some stuff go, right? I mean, mostly the decisions where people from outside of the intensive care unit are wanting stuff to happen, most of the time it's hard to imagine that those things are going to affect the patient's outcome. So, you know, a lot of the times I think it would be, you know, you're running into debates, you know, it's, should we continue giving antibiotics for another day? Who cares? You know, I mean, I do think you have to pick your battles. So if you see something that you believe is going to matter, then you totally need to go into bat for it. And sometimes you just need to do the thing that you think is right and make enemies. But on the other hand, for the things that your objective assessment tells you are trivial and irrelevant, then I would just say the best thing to do is to let it go. And I would say, you know, one of the things that is true is that the more gray hair you get, the less difficult these interactions become, right? So that speaks, I think, to the importance of the connection thing that I talked about, right? So when you've been around long enough to know how people operate and how people think, you can often come up with ways of expressing things or saying things or doing things that allow you to get the things that you want more of the time with less stress, you know.
It's a good point. I mean, I think that highlights the again, why junior people may do more, because they don't have that tool in their toolkit. They don't know you know, if you're a resident, you're just showing up to the service, or you're just a new fellow or even a new faculty member, you don't necessarily have the you know, just the nod across the room to the surgeon sort of that you might know from 30 years to be able to establish some kind of rapport. And therefore, you know, again, that's doing something, I suppose. Maybe that's the argument, that your connection is actually doing something, and it actually feels better than giving a liter of normal saline does. And it does less for the patient and everything to that effect.
Yeah, I mean, I think the other thing that's quite important is that actually part of the game, right, is knowing the way these different people that you interact with think about stuff. And I guess the classic thing, or in our sphere of practice, a critical thing, right, is how they think about death and how they deal with a situation where one of their patients is not going to survive. And you know, for example, I know that we have one neurosurgeon who, you know, I regard as insane, who basically, you know, the only way in which he will ever agree to stop treatment on anyone is if he believes it was the family's idea. There's no point in ever having a conversation with him about what he thinks the patient's prognosis is in any situation, because he'll always say, oh, it's impossible to know. We should carry on so that we can see, right? Whereas if you go to him with any situation and say, I've met with the family and they've really expressed a desire that we should stop because they think that the treatment here is intolerable, then he'll say, okay. And so knowing that that's the way in which he operates makes it very easy to deal with him, right? But if you don't know that that's the way that he operates and that's the way that he thinks, then dealing with him becomes impossible. And so I think you have to sort of learn how to navigate the personalities that you have to interact with in order to get the outcomes that are best for the patients. At least I think that's what you have to do.
I mean, I personally, I minimize, one of my strategies, which the trainees know about, is that I minimize any consultations that are ever issued in the unit, such that it minimizes the number of possible awkward interactions where you have to either politely dismiss or politely sort of feed the pigeons in terms of the 50 cc's of maintenance fluid or 30 milligrams of Lasix instead of 20 milligrams of Lasix as suggested by the, you know, the renal service, for instance. So yeah, the different mitigation strategies. Paul?
Yeah, I mean, I think that's definitely true of me too. So I try to avoid having conversations about things that I regard as manifestly trivial. And then I do, but I do also like the thing of the registrar comes to visit, and then when they suggest a thing, I suggest something completely different, and I tell them that if their consultant wants to have a further conversation about the dose of Lasix, that I'm immediately available on my phone for him to call me, which he never will.
Just, yeah, create a higher barrier to entry. Yeah. Dr. Cameron, and I don't know if others who've just shown their video want to ask a question as well. Okay, so Paul and then Karen.
Yeah, I just was wondering if you could comment on the concept of prescribing time for patients from an educational perspective, and in terms of restricting the variability. We ran 3 times a day in London, which I think predisposes itself to 3 decisions per day. But just the idea of saying, you know, with acute kidney injury, with the ATM, that's going to be time sensitive, rather than saying why you do or don't want to give fluids, the idea of imparting from a trainee, like how long does this septic pneumonia take before we would see them get better? Like how long are we going to do this? And the idea of prescribing time, if that sounds absurd or resonates, or what you might think about that idea.
So I think actually coming back to the discussion we're having before about interactions with nursing staff, I think actually there's something really important about the notion of time there, because I think sometimes, or a lot of the time actually, the code of the thing that the nurse says is, I'm really worried that the patient's crapping out, right? And so if you respond to whatever the question is by saying, yeah, I'm pretty worried about that. I'm pretty worried about how the patient looks as well. So we're going to keep a really close eye on things, and I'm going to come back in an hour and we'll see what's happened between now and then. That can definitely be as powerful as doing a thing, right? So acknowledging that there's a reason to be worried, or that you share the worry, is a good way of making the nurses think that you're not stupid, as opposed to dismissing the query as not something to worry about or think about. So yeah, I totally think that's a valuable thing to do in many situations. mainly time is the best diagnostic test that we have, right?
Karen?
Thank you very much.
Hey, thanks. Sorry, Paul. My name is Karen Bosma. Everything that you're saying, I'm smiling and nodding my head because it's really resonating. And what you just said was what I was going to add, so I don't really need to add further. But the key, I think, of acknowledging the concern that's underlying the question is so important. And just a quick example, like today at the bedside, the nurse said, patient didn't sleep at all last night. Can we have something for sleep? And I said, really appreciate you bringing that up. Sleep is so important. I acknowledge that, you're concerned about sleep, or acknowledging the reason for the question, can the patient have something to sleep? It's so important. But unfortunately, we don't have a medication that will preserve REM sleep. Anything we give will suppress REM sleep. And I'm really concerned that this patient needs that. So that's why I can't prescribe anything for sleep. But what we can do is, along the Paul Cameron lines of time, or what I want you to do is really focus on keeping the lights on during the day. We're going to do lots of physio today. We're going to really tire the patient out and see how tonight goes. And before we prescribe anything, just because, sort of the approach of acknowledging the concern and naming it, and then saying why you're not going to do anything, explaining why tapping the effusion is not in the best interest, or fixing the blood sugar, or whatever the example is. Just explaining why we're not going to treat it, I think can go a long way. And then the last quick point was, I really appreciated you acknowledging that there are some colleagues you're never going to convince, right? So I was thinking about, like, how does this apply to the liver transplant surgeon that wants an ICP monitor in the coagulopathic patient who's awake and talking, because we need to know what the ICP is. I just think there's some people that you're just going to have to fight and say, we're not doing that. And that's crazy. And knowing, I don't know if you have thoughts on how to pick those battles with colleagues that really want something done when you think this is not worth doing, and I'm not going to convince you of why you're wrong.
Yeah, I can't answer that question. I mean, that's impossible, isn't it? I mean, I think that you have a responsibility if the situation is such that you really actually believe that what's proposed is completely insane and it might cause harm to the patient. You have to go into bat for the patient then, I think. The difficulty is that if the practice is entrenched, then it's going to be very hard. It's very hard.
John?
Sorry, thanks again, Dr. Young, for the talk. I just had another follow question just regarding kind of more of a research perspective here. You've kind of mentioned kind of really eloquently that, a lot of the day-to-day decisions really are direct interventional physiology. And so we do kind of take a bit of comfort knowing that we can somehow objectively measure those kind of physiologic responses to our interventions like ICP or urine output and whatnot. But like you've also mentioned, that it can be pretty short-sighted, and there's kind of a large chain of benefit that needs to be followed until the patient actually realizes the benefits before the physician does. So kind of with that in mind, what is like your general thoughts and perspective on kind of balancing with pragmatism versus explanatory and mechanistic philosophies in clinical trial design? And with that, is kind of the paradigm of thinking for critical care physicians and the framework of how we approach problems, that's going to be basically dooming us to failing to reject the null hypothesis in most of these trials that are based on physiologic interventions?
So there's lots of stuff in that. I guess the first thing I would say is that while it's not all physiology, it's clear that it's partly physiology, right? So if the systolic blood pressure is 40 and you don't do something, the patient's going to die. If the oxygen saturation is 20% and you don't do something, the patient's going to die. If the ICP is 100 and you don't do something, the patient's going to die, right? All these things are self-evident truths. And they're basically the entire basis of intensive care, right? So the entire basis of intensive care really is, avoiding physiological extremes that will soon manifest in death. So the thing that's problematic, I think, is that when the physiological extremes are not in a situation where they're gonna manifest in death, then an inductive physiological rationale for making any decision could cause harm, and it could cause benefit. And it's quite likely that in a lot of situations, we systematically overestimate the benefit and underestimate the potential harm. So the way in which we resolve that, I think, through clinical trials for the things that are major physiological things that we monitor and act on, is by stopping pretending that changing any of those things is going to have a massive mortality effect, which is what a lot of clinical trials have done, right? So if you do a clinical trial where you say, I'm going to randomize the patient having a MAP target of 60 or a MAP target of 65, and I'm going to power that to detect a mortality reduction, absolute mortality reduction of 5 percentage points. Well, I mean, that's never going to happen, because there's no possible way that a treatment effect of that magnitude from that intervention could exist. But I think what's gradually happening over time in the field of critical care is that randomized controlled trials are testing treatment effects that are more realistic. We're getting larger, more collaborative trials that are being conducted across many centers in many countries, that for these physiological parameters are giving us the power to detect very small treatment effects, which are, I think, much more likely to be realistic. And once we start to test the treatment effects that are realistic, we're going to get statistically significant differences for outcomes that matter to patients, I think. Or if we don't, we're going to have such narrow confidence intervals that we're going to know that it's just not a thing to worry about. And if it's not a thing to worry about, then we shouldn't worry about it, and we should just worry about something else. And so the thing that sort of underpins the Megarocks trial, so the Megarocks trial is enrolling 40,000 patients, and it's designed so that in the event that we show no difference between the oxygen strategies that we're studying overall, we will be able to exclude a mortality treatment effect of either an increase or a decrease of 1 percentage point. We'll be able to say that the difference is less than 1 percentage point. So I think it's sort of believable, it's reasonable, I think, to say that if it's making a difference of less than 1 percentage point, it's probably not something you need to worry too much about. But on the other hand, if it turns out to be a 1.5 percentage point difference, then that at a population level for a ubiquitous intervention definitely matters. And I think, within the overall population, it's definitely plausible, I think, that there are some subgroups of patients where larger treatment effects than 1.5 percentage points might be realized. So the hypoxic ischemic encephalopathy subgroup, there are quite a lot of data from various sources suggesting that conservative oxygen therapy might be better for that group, and the magnitude of the treatment effect for that group may well be, higher. And so I think you need to acknowledge that in the study designs as well. And to get to your very final point, which it was about what about the initial mechanistic studies and physiological based studies? Well, I think the thing about those studies is that you need to view them as studies that occur as steps on a pathway that leads to a study that evaluates something that is patient important. Because we know from lessons that we've been taught time and time again that it's actually often deceiving to implement treatments based on physiological gain. So physiological gain can be important, and it may well be foundational in terms of getting to be in a position to do a larger trial with a patient important outcome, but it should never be the endpoint that drives the decision making. So that was a very long answer.
Oh, thank you.
Dr. Perry, did you have a question? You had your hand up. I don't want to. Was he frozen? Oh, there he is. Neil, did you have a question?
Yeah, sorry, I was a bit frozen there for a sec. Yeah, no, Paul, I'm one of the surgeon intensivists, and that was a brilliant talk. You basically, I said same sort of philosophy as well, and you just put it together much more eloquently than I ever could. I wonder, I've thought about this quite a bit, and is this just the penultimate clinical wisdom? This type of approach of sometimes, take your hands off the patient's the best thing.
Yeah, I mean, I think, as I sort of said earlier, I think that there is definitely a sense in which many people will move towards this position gradually as they move through their career. And so I think there is definitely an element of that. But there are still people who get through their career believing in magic, right? So it isn't an inevitable pathway that people will follow. But I do think, as you say, it's certainly part of it is it's the evolution of clinical wisdom over one's career for sure, most of the time.
Dr. Cadell, you've shown up to pose a question all the way from Halifax, Nova Scotia.
Thank you. That was tremendous. I think that was the second happiest piece of medical lecture that I've ever been to. The first, of course, being the Fat Man and House of God. So if I could mirror after those two sort of mentors.
Wow, that's just high level praise. Thank you.
I guess the way I looked at intensive care before starting was if you add intensivists to a CCU, people live longer. If you add intensivists to a CVICU, 24/7, patients live longer. Is that, and from now I've spent 2 years trying to find the secret sauce sort of thing. Is it just like the better coffee breaks? Is it a better recognition of, not chasing super physiologic or physiologic goals? Or do you think that intensivists inherently recognize that population C that you were talking about, this person's sick and there's some potential gains to be made there versus A, B, and D, maybe there's less juice to squeeze?
Fundamentally, actually, I believe that it's more to do with the nurses than the doctors. So I think the thing about intensive care is there is really no substitute for having a highly skilled intensive care nurse who understands intensive care, spending time with the patient and telling you when the patient's, going badly. I think that's basically what it boils down to. I don't really believe that the doctors have much to do with it at all.
What do you say to that, Andrew Cadell? After 8 years of postgraduate training to become the best doctor imaginable, you could have just gone to nursing school. Is that sort of for 3 or 4 years?
I'm going to politely ignore that question. I guess the second part would be if there's anything that an intensive care physician can. It seems like you believe in sort of collectivism over individualism, in that like the individual ICU physician, if you think that you make a difference, you're acting for yourself as opposed to the group. Do you think that like things like bundles or bringing like quality standards like that might make a difference as an intensive care specialist, ensuring that like the basement of care is high enough? Or is it just I should be going back to nursing school for PGY 9 through 12?
So like, I don't want to completely dismiss the stuff that we do, right? So we do actually do stuff. It's just that I think that the thing that makes people do better in an intensive care environment compared to non-intensive care environment is the intensive care nursing, right? So that's what I think is the thing that makes a difference to the treatment that the patients are receiving. And tell me what your question is again, because I've distracted myself.
I guess my question boils down to, do we do anything? Do you think that we, the bundles we bring?
Oh yeah. So that was what I was going to say. So in my intensive care unit, we change the person who looks after the patient, the specialist who looks after the patient every day. So we have one person who's on call for 24 hours, and then the next day they hand over to another person. And in the main, most of us go to the morning handover every day. The thing that does in terms of the treatment that we deliver is it eliminates outlier behavior. So because everybody changes every day, anyone who deviates far from the median it's like whack-a-mole, you know, you get whacked back to the middle again. And so I think that there is a real strong case for, you know, like treatments that are moderate and that the entire collective believes are reasonable as being the right treatments. So I think that it's actually achieving that sort of moderate balanced treatment that kind of falls within a consensus of the entire group as a pathway to delivering good care. Now, I don't actually think that necessarily means following guidelines, because a lot of the time what gets into the guidelines is nonsensical, and it doesn't actually reflect moderate or reasonable behavior. There's a lot of vested interests and loud voices, and the things that end up going into guidelines don't necessarily reflect consensus or a moderate approach all of the time. So I think a much better yardstick than what's in the guidelines is actually, am I doing something that all my colleagues would do? And if I am, that's probably okay. And if I'm not, then maybe it's not.
Thank you, Paul. I think that would be a good spot to wind things down, and I'll make one last final call for questions, burning questions. Paul, you've been extremely generous with your time and fielding, I think, a wide swath of questions. I want to particularly note that, you know, you're regarded obviously as one of the great clinical trialists in critical care these days, and we just spent an hour and a half or so largely discussing clinical epistemology and philosophy of care, highlighting the range of your intellect and contribution to the field, and the fact that you were able to do the granular level research and also basically bring that up to a higher level of abstraction to talk on and help us move through our thinking on some of these topics. It's really an extraordinary display, and just so grateful that you would take that time with us today. So you've enriched our group, and I want to thank you on behalf of Critical Care Western and our group here in London, Ontario, for bringing Wellington to London, Ontario. And we hope to maybe do this again with you sometime in the not too distant future.
No worries. Thank you very much for the opportunity. It was great fun. Thanks a lot.
Thanks so much, Paul.
Later. Bye.
Okay.